And this is about quality control in creating a culture of patient safety. So everything that we've been learning about in nursing school is about patient safety, keeping the patients alive, keeping them safe. Quality control is the last step of the management process. So when we are determining our quality measures and the outcomes, it is something that we're constantly reevaluating. Performance is measured against what the predetermined standards are. So there are, we've talked about like clinical practice guidelines. There are clinical standards as to how to take care of a patient with this disease or this scenario. And we have to measure what we're doing against what the top organizations, the top hospitals are doing wherever you work. What is the national average? Where are we falling? And what can we do better? Or potentially, if we're seeing adverse events, what can we do? Because that's causing us obviously to have patient harm. What can we do differently in order to improve our outcomes, improve patient safety? And then we make changes and we constantly reevaluate. Did what we change, is it working? Do we still have room for improvement? What can we do different? And it just keeps going. So there has to be periodic evaluation of the mission, the goals of the organization, the unit, what the objectives are. We measure our performance against what the standards are, and we also benchmark against how other organizations of our type are doing. So do we meet what the national average is? Are we above? Are we below? And then we have to audit the outcomes. So especially if changes are being made, we have to make sure that we're moving in the right direction. The hallmarks of effective quality control is that you get support from the very top people. It's really, really difficult to make organizational changes if you don't have support from the top level administration. That is absolutely critical. The organization has to have a commitment regarding human resources, the financial component of it, because these programs, these quality control measures, they take time, they take money, and they take personnel who have been trained how to implement them, how to gather the information, how to evaluate their progress. And it has to be continuous. And that's something they look for. So a lot of times you'll see it as CQI, continuous quality improvement, because we don't just make changes and say, yep, fix that, we're good to go now. It's constant reevaluation. So they talk about the 3 steps of the quality control process, is that the standard has to be determined. So standard of care, clinical practice guideline, whatever it is, that has to be determined. We have to gather information about whether or not we met the standard, and then what our corrective action is if we didn't meet it, and then we reevaluate again. We do this in nursing education. There are standards that we have to meet. So I'm just gonna make these up. 80% of students in NUR 445 have to pass the ATI with a level 2. So that is the standard. Well, if we just made a standard and then we never evaluated whether or not we met that, we won't know how we're doing. So we collect our data, how many students in that particular cohort got a level 2 or higher? Does it meet the minimum requirement of 80%? And if it doesn't, what can we do differently next time the course is taught so that the majority of the students, 80% or greater, do achieve a level 2? We do the same thing in healthcare. So there's a particular standard. We see how the organization is doing against what they say that standard dictates. And then we have to make those adjustments, and it's going to be evaluating at the end, making further adjustments, and the process just keeps going. American Nurses Association has played a huge pivotal role in developing the standards for the profession of nursing. So they're a key player in where we get a lot of our standards from. Something known as the quality gap. So you've got let's say the top performing hospitals in the United States, and then the difference between where the national average is. So again, totally throwing numbers out. Let's say 60% of hospitals fall around the middle level of having falls in the hospital, annual falls. Everyone, national average is right around that middle ground. So we'll say 50%. But then we've got these top performing hospitals that are only seeing 10% falls over a given time. The difference between those top performers and the majority of the other organizations is what's known as the quality gap. Other industries typically have a pretty small quality gap. In healthcare, it can be huge. So we want to know what is causing this gap. Why are those organizations only experiencing such few patient falls? And the majority of the hospitals in the United States are having these high numbers. That's the quality gap. And we have to identify what can be done in order to get up to where those high performing organizations are at. We do benchmarking. So that is measuring our services and our performance against those best performing companies or hospitals, or in my case, it was against the best performing surgery centers. And then we want to identify how they differ from us and use those differences as a standard for us to improve our performance. So there were certain things that we always had to report. And I'm going to show you what some of these look like. I tried to pull some of the things that we had to report. Can you all see this? Can you see this screen here? So being that, and the rest of it, I tried to pull for hospital, but this is what I'm most familiar with. So it was the ASC, which is Ambulatory Surgery Center Quality Collaboration. And these were all the different measures that we had to report. So you see hospital transfers. Technically an outpatient surgery, if you're doing an outpatient surgery, the goal is the patient goes home. If they end up getting transferred to the hospital, it's kind of looked upon as maybe that patient wasn't a candidate to be done in an outpatient center if they ended up needing to be transferred to the hospital. Sometimes it happens and it was completely unexpected, like new onset AFib. They didn't have AFib when they came in. We weren't expecting them to have AFib, but they went into it, so they got transferred. But we had to report when we had to transfer a patient to the hospital. Emergency department visit within 1 day of discharge, because that means that the patient is having some sort of untoward event. They're having a complication or an issue. So we would have to keep track of who went to the hospital, how many hours it was from their surgery, and that was reportable. Hospital admission, there's more. We had to document every time we did surgical site hair removal, because it can lead to damage to the skin if it's done incorrectly, especially if it's done with a razor, not a clipper, and it can lead to surgical site infection. So we had to document all of that. And every day we had to tally up how many people got clipped over how many surgeries we had for the whole day. And these were numbers that were reportable. Body temperature. So, you know, I could keep going. If a patient suffered a burn. And so we're looking at where do we hit versus where the top performers are. And how come, you know, 20% of our patients are becoming hypothermic when they're experiencing like less than 2%. And so then we need to make our practice changes in order to try to achieve where those top performers are. So benchmarking, very, very common as to how we improve our performance. And you'll often see that as quality improvement. Now, who remembers the difference between quality improvement versus like nursing research?
Quality improvement is within an organization.
Correct. It's going to benefit this organization. So in my circumstance, let's say we were seeing, you know, 20% of our patients becoming hypothermic. We're going to make changes within my facility to try to be at a higher benchmark so that we're with the top performing who are less than 2% of their patients. But any improvement, quality improvement projects or implementation is going to affect my organization only. I'm not looking at it as far as it could be made into a nursing research, but that's not what it is at this level. It's benefiting my organization so that we improve our patient outcomes, because we know patients who become hypothermic have delayed healing. They're at an increased risk for DVT, PE, and all these issues. Another thing that we look at, and I briefly, I think, spoke about this last week, is that we look at critical event analysis and root cause analysis. And so when we do a root cause analysis, it's following an adverse event to try to figure out how it happened. And then what can we do to prevent it from ever happening again? So if you have a wrong site surgery, let's say, and so the patient in recovery, we determined that they operated on the left knee and it was supposed to be the right knee, that is grounds for an immediate root cause analysis. We have to go through and piece out every single step from when the patient was at the doctor's office, got scheduled, till they walked in the door, and every step until they made it to the operating room, and figure out how did it happen that the provider operated on the wrong extremity. And so the whole goal of that is to make sure this is preventable. Wrong site surgery is 100% preventable. The ball got dropped somewhere. And so we need to identify what happened. It could have been a break in communication. Remember I told you guys the story, not my surgery center, but another one, where a patient brought in the paperwork explicitly stating they did not want and would not accept blood products. And that paper was buried in the patient's file. It never made it to the operating room personnel. During surgery, the patient lost blood and they were transfused. That is evidence for a root cause analysis, because they have to say what happened and how can we fix this so moving forward it never happens again. And all of this has to be documented, typically with like a root cause analysis, multiple people. So you're going to have like the administrator, medical director will often be involved, all the people who were involved with that patient's care, so nurses, anybody along the way will be involved so that they can try to help identify what caused this preventable error and how can we make changes moving forward. And so, you know, really important sentinel events like a death, a preventable death, that has to be investigated. A fall with injuries has to be investigated. A wrong site surgery, those types of things require immediate digging into so that it can be prevented moving forward. Then there's different audits that are used with quality control. If it's a structure audit, then they are looking at the setting in which that patient care occurred. So, you know, looking at the unit itself. If it's process, that was how the care was carried out. And if it's an outcome, then that's what we're looking at. We are looking at the results, the patient outcomes that occurred following specific nursing interventions. So structure is the physical unit, the process is how it was carried out, and then your outcome is what was the patient's outcome following the set of nursing interventions. Nursing sensitive outcomes, those are growing recognition. And that is the outcomes that are nursing sensitive, and that helps to create accountability for us as a profession. Nursing wasn't always a profession, but now we have accountability, we have autonomy, and we have things directly related to the care that we provide. So we look at outcomes directly related to the nursing care that is provided. And that all goes into us developing the profession of nursing and advancing the profession of nursing. So there's going to be more provider sensitive outcomes, medical outcomes, and then we have our nursing sensitive outcomes that we look at. How do we arise at clinical practice guidelines? What do we do as nurses in order to determine the step-by-step interventions that we're going to do in order to provide quality care? Where do those come from?
research?
Yes. Now we tie in what we learned last quarter. It's not because Nurse Sally has done it that way for 25 years. It's because we've done research, and the research tells us that together with the expertise of the nurses and the patient their preferences, that this is the best step-by-step guideline in how to carry out a specific nursing intervention. So evidence-based practice, that is a critical component to it. Big push, it's gone from quality assurance to quality improvement. And a lot of that is because it's a continuous process. Some companies have a quality assurance group. So I don't know if you work for like a meat packaging company. I don't know where I come up with some of this stuff, but if you work for like a meat packaging company, there's a QA department who is looking at the quality of the product that's being produced. So they want to make sure there's no like foreign objects in there, that it meets all the requirements. In healthcare and in nursing, we're doing quality improvement with ongoing evaluation, surveillance, and constantly improving. Very rarely, if ever, can you make a change in healthcare and say, yep, we fixed it. We don't need to do anything else as it relates to that. I implemented for my doctoral project a communication line in my surgery center because everybody was frustrated. The ball got dropped frequently due to lack of communication between the different areas. And it sounds so simple, but communication and lack of communication is one of the biggest reasons why medical errors occur. And even in smaller units, it can happen. And it's frustrating for everybody involved because you want to do what's right, but if you're not given the information, how can you really do your job? And then of course you feel bad when something gets missed or a patient harm occurs because of it. But you don't just make some communication guidelines, implement it. Like mine was a communication sheet because we weren't always available for verbal report. That way, any of those really important indicators were marked. So no matter who came to the patient's file, they were able to see right off the bat that there was an allergy, that they had an implanted metal device, whatever it might be. But you don't just make something like that and say, we fixed it, everything's on here. It's constant reevaluation. Like, is there some stuff that we have on here maybe we don't need? Is it redundant? Have we noticed that there's stuff missing from this form that we could add? And so it takes that just continuous process. Healthcare changes, our technology changes. And so the things that we're doing change. And they may not even be using the paper form anymore. It may be all electronic now, who knows? But you have to adjust to the times and to how healthcare evolves. And so we are considered more quality improvement in how we carry these things out versus quality assurance. It goes over 2 models that they use that you can look at, and then the Joint Commission. So the Joint Commission is one of the major accrediting bodies for hospitals and healthcare organizations in the United States. They often will come and do surveys, usually get surveyed about every 2 years or so. I'm not sure in the hospitals, it may be a little bit longer than every 2 years. And they want to make sure that the organization is following guidelines and meeting all of the criteria. And one of the things that the Joint Commission is responsible for is annually, they develop what's known as the National Patient Safety Goals. So I pulled 2021 so that you can see, because every year they change these. Now, just because they change them doesn't mean they're going to be very different from year to year. There are some things that have been on the National Patient Safety Goal for years because it's an ongoing problem. So let's look at a couple of these. Identify patients correctly, using at least 2 ways to identify patients. You guys learned how to do that in school. That has been a safety goal for years, and it's likely not to go away because when we don't appropriately identify our patient, it is highly likely that you will end up having the wrong individual or they will receive the wrong treatment. So that's something that stays there. Improving staff communication. And now these are, you'll notice these are the hospital NPSGs. I use the ambulatory surgery center ones. So they have them for different areas, but these are the hospital patient safety goals. Improving communication, using medicine safely. So making sure that medicines are labeled. You have to have a labeled medication. If Joint Commission comes in and they are doing a survey and they see medication drawn up in a syringe with no label on it, that's a huge ding. We call them dings, but that is a huge error. Can't have multiple medications in an area, especially if they're not labeled, because then you're going to forget which one's fentanyl, which one's Versed. We have to be careful with patients who use medicines to thin their blood. And then recording and passing along correct information about a patient's medicines. Using alarm safely, making sure that the alarms work on our medical equipment. And so based off of last year's events, these are the patient safety goals that they determined were the most important focus for 2021. Preventing infection, identifying patient safety risk, reducing the risk for suicide. That's up. So that's going to be a focus for 2021. Preventing mistakes in surgery. So preventing wrong site surgery, been on there for years. Making sure that the patient's body part is correctly marked. That has been on there for years. And then pausing before the surgery, it's called a timeout, and that has been on there for years. You have to complete a timeout before surgery, and that's when you stop the operating room. Nobody can be doing anything. Everyone has to be attentive, and the nurse, the circulator, will read the consent form word for word, and everybody is in agreement that the consent form is right and that the patient is marked, and they're kind of dotting their I's and crossing their T's to make sure that a wrong site surgery doesn't occur. So every year I would pull the Joint Commission National Patient Safety Goals and see what the focuses are for that year. You'll notice that they don't differ that much year to year, but if they start seeing a big rise in something, it will get put on here. So that's your National Patient Safety Goals.
Dr. Simmons.
Uh-huh.
So that was a question on our ATI about going into surgery and the timeout. So if it's an emergency surgery, do you still do a timeout?
Yes.
Okay. Right. We were all a little confused. We didn't know. We're like, I don't know, it's emergency. Like they have to do it really fast.
Yes, but it's done quickly. But you still have to verify, because you could be doing an emergency surgery, and with emergency surgeries, when you're rushing, that is when you're more likely to make a mistake. So timeouts are quick. They don't require a whole lot of time, but it's everybody verifying that this is the right patient. We're doing whatever that surgery is on the right body part. It takes seconds to do it correctly, and it prevents tons of errors. So yes, it still needs to be done.
Okay.
And that's a very, that can be very difficult, because there are providers, surgeons who don't want to stop for a timeout. They give the nurse a hard time about it. It can be sometimes a bit of a battle, but there's like a whole timeout week, and I can't remember what month it falls in, but there's such an emphasis on making sure the timeout is done, because it protects the patient. And you can't, scrub techs can't be on their back table messing with instruments. Like, everybody is supposed to stop, look at you, and be listening. No chatting, no radio on. Like, it's a very important, it goes quick, but it's absolutely critical. I pulled the CMS. So CMS is Centers for Medicare and Medicaid Services. Anybody who is a CMS provider, so if your hospital accepts Medicare and Medicaid payments, you are under the guidelines of CMS. And I mean, you really have to adhere to what their guidelines state, but they have outcome measures. So I just want you to see the different things that they're reporting. 30-day risk standardized mortality measures for these diseases, readmission measures for these diseases. So they're having to tally and report when these individuals get readmitted to the hospital. a 90-day complication. So they have to follow these patients for 90 days after surgery to see if there's any complications that develop. There's a whole bunch. If you look on the CMS website, I know you guys don't have tons of time, but when you get out into the working world, it is important, especially if you do anything with quality improvement, outcome measures, that you just kind of navigate and know where some of this information is. I tried to really stay focused on hospitals. This is the Agency for Healthcare Research and Quality. So there's an area under here where they have toolkits. So let's say in your facility, you're dealing with a lot of falls. They have toolkits available for fall risk reduction. And it's already been mapped out with all these different implementations that are known to help to decrease the risk of falls. You see this one's regarding communication, community-acquired pneumonia. There's tons of them. So if you are looking at something within your organization, even if you're a staff nurse, and you notice that you guys are seeing, you know, a high rate of whatever it is, here's reducing Medicaid readmissions. Look at the toolkit, see if something isn't available that you can bring to your supervisor or the department manager and say, you know, we're having, for whatever reason, so many falls. And there's this toolkit that has been developed that will help you implement. I mean, hopefully all of this is already implemented, but, you know, alarms on the bed, non-slip socks, the wristband that identifies high risk, a high risk assessment for people meeting X, Y, and Z, you know, whatever, getting up with a gait belt and a nurse being present for these diseases or these surgeries. And it's just nice that this has already been laid out, and then you tailor it for what your organization needs, because it's not a one size fits all. This is also from CMS, and these are the different measures. Again, these were hospital. These are the measures and the frequency that you have to report them and that they get updated. And so you notice here's that patient survey, the HCAHPS. And so all of that's reportable. You can go on and pull a hospital and see their rating for their HCAHPS surveys. There's something known as pay for performance that came with the whole Affordable Care Act. And that part of it is they look for these HCAHPS results. They look for outcomes. So if certain patients suffer a fall or a surgical site infection that could have been prevented. So mostly they focus on preventable occurrences. They may not pay the facility if the patient suffers one of those preventable occurrences. So there's a lot of different things, but you can look up a organization's HCAHPS. And it talks about communicating with the nurses, the physicians, the responsiveness of the staff. And again, you have to think from the patient's perspective, what's important to them. Could have saved their life and they could have had no complications. But if their lunch was consistently late, it's going on their HCAHPS survey, guarantee you, because their perception is that the hospital is not responsive, which is unfortunate. But we look, you know, they look at all of that. So those are all with HCAHPS. Timely and effective care. So they're looking at preventing sepsis and septic shock. Normal colonoscopies, how often are they being rescheduled? We had to document that as well. So you can, if you can imagine how many different things are tracked and measured and reported, and you have to see where is your organization hitting versus the national average versus those top performers. What is that gap called? Between the echelon group and where the majority of the organizations are. What was that called?
Is it quality gap?
Yep, the quality gap. So if that is found, we have to figure out, why is there such a gap? What can we do? What are the exemplars that can be implemented to get us to where those top performers are? Let me see if there's anything else I want to talk about. Joint Commission, you've got to know that they're a huge accrediting body. They have a lot of the standards in place that hospitals and organizations have to follow. This goes over the pay for performance, which I kind of just talked to you about. The HCAP survey that is being implemented. It's a big focus in healthcare. I know your screen's a little small, but I don't think that I'm, oh, let's look at these medical errors. Oh, wait, hold on. Okay, is it big again? I'm assuming it's big again, thank you.
Yes.
So medical errors. You would think that today in 2021 that we wouldn't have the amount of medical errors that we do. They've gotten worse. They have increased. Again, a lot of them are due to poor communication. There is an increase in medical errors amongst new nurses. We've talked about staffing, healthcare in general, where a lot of times the personnel are overwhelmed. They've got too much on their plate, and that's when people are in a hurry, unfortunately, that's when things happen. So if we ignore that medical errors are occurring, then that does nothing to try to eliminate them from happening. Medical errors happen. What we have to do is try to figure out how can we prevent them, and we have to take the initiatives to prevent them. So you'll notice that more things are being reported, or you will notice as you get involved with healthcare. Before, we only reported a small number of instances, but now there's all these other reportable measures because we know that they lead to medical errors. The Leapfrog initiative we'll go over in just a second. Other things that have been implemented. So, you know, in the hospital, you scan a barcode that matches the patient to the medication that you get from the pharmacy. Well, that didn't used to exist. Where did it come from? It came as a safety measure to eliminate human error and make sure that we've got that right patient. So you're seeing barcoding, smart IV pumps, and not the IV pumps that are at the school, but there are these very intelligent IV pumps that will only operate under certain circumstances when it's safe. Medication reconciliation, that is something that was implemented on every single patient. So on admission and in every department, you have to acknowledge the medication reconciliation. So that contains every medication the patient takes, the dose, the timing. That includes over-the-counter, supplements, vitamins, herbs, allergies with reactions. It is all supposed to be complete. And so if the patient's in the ED and then they get transferred to PCU, that is supposed to be reviewed again, so that each person along the way has an accurate medication reconciliation. So what do you think the purpose of a med rec is? Why do we have those?
To know drug-to-drug interactions.
That's the big one. Yeah, that's a huge one, because we're likely to be administering medications. They're going to get new prescriptions. And if we know all the meds that they're on, we can pick up if there's going to be a drug interaction, if there's going to be an adverse reaction because they have an allergy, a cross sensitivity, we can identify that. So those medication reconciliations were developed to try to prevent the medication errors, which is a medical error. Leapfrog group initiatives, that is computerized physician provider order entry. It also involves evidence-based hospital referral, staffing a physician in the ICU. So you'll notice in the hospitals, and I'm sure you've had experience with some of them, but a lot of things are done electronically where physicians can put orders in, because there is a bigger risk of verbal orders than if something is put in the computer by the provider. So what does that whole process look like when you take a verbal order? You're on the phone with the provider and they give you an order.
You want to write it down and read it back to the provider?
Say that one more time, sorry.
You want to write it down and then read it back to them?
Read it back, absolutely, because you may have heard something that's not what they said. And you always clarify. If they talk too fast or if it was noisy, you clarify. So you write it down, you read it back to them, and then they have to sign off on it the next time that they are physically at the facility. But always do a read back. And I always documented it, verbal order, read back, signed my name, the time, all of that good stuff. But that's really important because there are, I'm sure you've learned about this in pharmacology, like look-alike, sound-alike drugs. And you may have heard something and that's not what the provider said. So never feel rushed to get off the phone and never bypass reading it back. So anyway, all these different systems have been implemented to try to decrease the amount of med errors that occur from verbal orders. Just like with dosage calculation and writing out certain things, you know, we're sticklers on you have to have a 0 before a decimal point because it's simple things like that, that if they're not on the piece of paper, a tiny decimal point can be completely missed. And if it was supposed to be 0.5 milligrams and you end up giving 5 milligrams, huge difference, huge. So these things you have learned are to prevent errors that are occurring. I'll try to find some latest evidence of nursing, the errors that are occurring and involving nurses. It's really scary. And you just want to do everything you can. You know, some things are going to happen, but we want to do everything we can to make sure that those don't occur on our watch. So we are going to look at a case study, same players here. Beverly is attending a quality improvement team meeting, and the team is discussing the increase in the rate of client falls on the med-surg unit. Before the meeting, she reviews the QI process with Cynthia, and Anna Hartman, who's a risk manager, is going to lead the team in a discussion about nursing sensitive indicators. They're also going to discuss magnet recognition program and then the use of root cause analysis to determine the possible cause of the increase in falls. So it's really everything that we have been talking about today.
Hello, Cynthia.
Hello. You wanted to brief me about the quality improvement meeting?
Yes. I think this will be a good learning experience for you. Before everyone arrives, I want to review some basic information with you.
Okay.
First, let's talk about the quality improvement process in general, and then we can talk about how we use an audit to study client outcomes and improve the quality of care. So tell me what you know about quality improvement in the audit process.
Cynthia is explaining her understanding of QI to Beverly. Which of the following statements by Cynthia requires further teaching? So you're looking for a false statement. The Joint Commission mandates that accredited agencies have quality improvement programs. Quality improvement measures the degree to which an agency has met a criterion. Nurses who provide direct client care are an integral component of the quality process. Any guesses?
Would that be a second one? Quality improvement measures the degree?
So you think it's this one?
Yeah.
Okay, because it's saying that the QI measures the degree to which an agency has met a criterion.
Mm-hmm.
Anybody thinking anything different?
Maybe the third option.
Nurses who provide direct client care are an integral component of the quality process. And remember, always go back to your question. It's asking for which one requires further teaching.
Just kidding. Said that.
Anyone think it's anything other than the second one? And that is correct. So yes, nurses are a huge component of the quality improvement process. And according to Joint Commission, you have to have quality improvement programs. When they come to do surveys, you have to show them all of your QI projects. and how you've remeasured and all of that. It has to be written out explicitly. Oops. Sorry. Beverly is asking Cynthia to identify the steps in the audit process. Cynthia states that after determining the topic to study, the next step is to identify data collection methods, establish criteria for quality care, or develop an audit tool. You have your topic, so what do you think would be next?
Number 1.
Identify data collection methods.
I think it's establish criteria for quality care.
Okay, so 1 for number 1, 1 for number 2. Who wants to break the tie?
Establish criteria for quality care.
Okay, let's see. And that is correct. So once you know the topic that you're going to study, before you even decide how you're going to collect the information, you have to establish what are we determining is quality care. Then we'll go into the data collection and developing the tool in order to gather our data. Beverly is explaining to Cynthia that a quality improvement team can conduct a structure audit, remember a structure audit, to measure the quality of care. Which of the following fall-related factors are appropriate to include in a structure audit? The nurse-client ratio at the time of the fall, the frequency of rounds by the nursing staff prior to the fall, the length of the client's hospitalization after the fall.
The nurse-client ratio?
This first one,
Yeah.
I agree.
you agree? Correct. So remember, that was about the unit itself or the facility itself. Good job.
Thanks everyone for coming to the meeting today. I believe Beverly's going to start us off.
Thanks, Dwight. First, as you can see from the data, there's been an increase in the rate of falls on our unit.
Yes. So the most important task for our team over the next few months is to analyze what's causing this increase. Then we can take steps to modify our risk intervention plan.
I agree. And a good way to accurately evaluate the increase in falls is to conduct a comprehensive audit, which includes 3 components. The first is structure, which is the setting where nurses provide care. Next is process, or how nurses provide care. The last component is outcome, the results of how the nurses provided the care. We need to pay attention to outcomes that are nursing sensitive.
Nursing sensitive?
Yes, there's usually a correlation between the care nurses provide and specific client outcomes. This is particularly important at this time because the hospital is considering seeking magnet status.
What is magnet status? How does that correlate with the number of falls on our unit?
Well, the magnet recognition program is very complex. It started as a nurse retention program and currently focuses on the quality of client care and exemplary professional practice.
Oh, this is all very interesting and a little overwhelming. Can you help me and maybe some of the other members on the team with a summary of our discussion so far and what we need to discuss next?
Sure. Let's continue our discussion about nursing sensitive outcomes. Then later, we can talk more about the magnet recognition program. We'll end by talking specifically about factors that place a client at risk for a fall by analyzing the structure, process, and outcomes related to client falls. Now, back to the topic of nursing sensitive outcomes. Who can give me some examples of nursing sensitive outcomes?
I can provide some examples.
Cynthia responds when Anna, the risk manager, asks the quality improvement team to list nursing sensitive outcomes. Which of the following examples indicates a need for further teaching? So again, you're looking for something false. Urinary tract infection rates, pressure ulcer rates, primary cesarean birth rates, nursing sensitive outcomes. Which one?
Primary cesarean birth rates.
Okay, anybody else think it's anything different? And you got to kind of think of it, what do nurses have a direct relationship with? What do we help to control? And that is correct. So it's what do we focus nursing care on? Preventing infection, preventing skin integrity, breakdown, that type of thing. Good. Anna's discussing the magnet recognition program with the team. Which of the following information should Anna include? The American Hospital Association developed the magnet recognition program. Magnet healthcare organizations must collect data about nursing sensitive outcomes. Magnet healthcare organizations must publish their nurse to client ratios. Just use your best deductive reasoning. So you're looking for a true statement regarding magnet recognition programs.
Didn't she say that it, like she had said the definition or whatever of a magnet healthcare organization, then she said, let's talk about nursing sensitive outcomes. So I'm gonna go with B, but.
Okay. Anyone think it's anything different? Good job. That was it. Anna and the staff at the quality improvement meeting are discussing the increase in the rate of falls on their unit. Which of the following is an iatrogenic risk factor that can increase a client's risk for falls? Iatrogenic, you have to remember what that word means. Decreased visual acuity, urinary urgency or nocturia, type and number of medications prescribed for the client.
I feel like it would be C.
This last one?
Yeah.
Okay. Anyone think it's anything different? Who remembers what iatrogenic means?
Doesn't it mean like caused by something that like the hospital's doing?
Yeah, so it's usually like healthcare induced. Correct. Very good.
Thank you, Anna. Are we ready to move on to our next agenda item? Fall risk factors.
Sure. So we're planning to examine the fall rate in our unit for the last 3 months, right?
Yes, we're actually going to study the fall rates over the last 4 quarters, which includes the last 3 months.
Can you tell us how we calculate the number of falls during a certain period of time?
You bet. We can begin by looking at this graph. You'll notice that the graph shows the total falls per quarter for your medical surgical unit over the last fiscal year.
The quality improvement team is reviewing a graph which depicts the rate of client falls on their unit for the last fiscal year. In which quarter was the fall rate the highest? First, second, third, or fourth?
Fourth.
So it's fall rate per 1,000 client days.
Fourth.
Yeah. And so it's easy to use a bar graph like that where the information's just very easy to understand. We had the most falls that month. It's the one that goes the highest. Anna is explaining how to measure the rate of falls for a specific unit. When reporting fall rates, which of the following is an appropriate way to calculate this number? The number of client falls per 1,000 client days, the number of client falls during the previous fiscal year, the number of injuries from client falls per 1,000 staff days.
The first one.
Anyone think it's anything different? Correct.
So in examining our fall rate, we look at the number of falls per 1,000 client days, which is,
that's right. If we only look at the actual number of falls over a period of time, it doesn't give us a very accurate measurement. If the census is down, that factor alone can lead to a decrease in the number of falls.
Oh, I see. And if the census is up, that factor can lead to an increase in the actual number of falls.
Yes, you're correct, Cynthia. You can see that for each quarter of the last fiscal year, the highest fall rate per 1,000 client days was 8.7 in the fourth quarter. It was the lowest in the third quarter. It was 4.5.
Okay, so now that we know this, what is our next step?
Well, we need to conduct a post-fall root cause analysis. And the root cause analysis.
I'm assuming this is going to be about the RCA. Quality improvement teams planning to conduct a post-fall root cause analysis. Which of the following should Anna include in her explanation of root cause analysis? RCA includes finding a single cause for the problem. RCA evaluates the consequence of a sentinel event. RCA is a way to determine the origin of a problem.
That one, the last one.
Anyone think it's anything different? Good. Oftentimes, it isn't a single cause. There are often multiple things that occurred that led to the event to happen. And that's why you really have to do this in-depth investigation to figure out exactly what happened to improve the process. The Quality Improvement Committee is ready to begin the RCA process. Which of the following is the first step the staff members should take in relation to identifying the root cause of the increased incidence of falls on their unit? So this is the first step. Examine the circumstances related to each fall, develop a causal factor chart, identify possible causes of the increase in client falls.
The first one?
Examine the circumstances. Okay, anyone think it's anything else?
Maybe the last one.
Okay. Can I get a third?
I think the first.
The first? And that is correct. So you have to look at what happened in each of those scenarios to really try to get a good starting point before you
What's
even.
the difference between those though?
So here you're identifying what possibly caused the client to fall. Here you're looking at just the whole circumstance. And so you're going to know the patient, their medical history, what meds they were on. Like you really look at the big picture and then you start honing in on what could have actually led to the fall.
Okay, thank you.
Yeah, so in the first one, it's going to be much more all-inclusive so that you get an idea of who the patient is, what they were in for, what type, had they had surgery, new meds, you get a list of all of that. And then we start identifying, well, out of all of this scenario, is there something that could have actually led to it? It could be the introduction of a new medication that caused orthostatic hypotension. That's where we start identifying the possible causes. Oh, and I guess that's it. Yep, that was it. So hopefully those have helped just kind of work through the material just a little bit. Make sure you've read, you've got your second exam Friday. We're going to go over Friday delegation at length because that is an area where quite a few people are still weak, and that is a topic you have got to make sure you understand. As a practicing nurse, you're going to be delegating. And then, of course, just to make it through this course, the ATI, your NCLEX delegation is a huge component. So we'll spend additional time on that on Friday. Anyone have any questions about anything that you want to discuss? I know we're ending a bit early again, but I'm here if you have anything that you want to go over.
Can we just do Friday's lecture now?
I don't know that I can do that. Well, why don't we do this? It's about 3:06. Why don't we come back at 3:20? Let me see what I've got together, and we can go over some of the delegation information if you'd like. So that would cut down class on Friday. So yeah, I'm more than willing to go through whatever I can today. So we can do that.
If
So
that's what you guys want, it was just an idea.
no, it's 2 hours before class ends.
Okay.
So yeah, no, that's absolutely fine. That will cut down class time on Friday. So if you guys are fine with that, I'm fine with it. You can go on break, and then if you'll come back around 3:20.